Welcome back, everyone. This is Dr. Giuliano. We're going to be talking about post-traumatic stress disorder now. This used to be in the classification under anxiety, but now it's in its own category. The lifetime prevalence of a traumatic exposure for someone in the U.S. is anywhere between 40 to 90%. A lot of this depends on the environment that you're exposed to, while the lifetime prevalence of PTSD is only between 1 to 9%, or around 6.8% in the U.S. Exposure to a trauma and the intensity of a response increases the risk, but there must be other factors also, because there are people that are exposed to traumatic events that do not develop PTSD. And some of these may be things such as genetic factors or other factors that have not been identified. History of childhood sexual abuse does put people at an increased risk for PTSD. This can occur, and PTSD can occur at any age. There's a high amount of concurrent depression or other anxiety disorders, and a lot of these patients will suffer from alcohol abuse or dependence. And even 20% of these patients attempt suicide. The average length of symptoms for patients being treated is 36 months, versus if they don't receive treatment, the symptoms can last for up to 5 years or even longer. The pathophysiology of PTSD is not well elaborated. There are some hypotheses that it is associated with changes in neuroendocrine, immunologic, and neurochemical systems, but the exact mechanisms are very poorly described, which is going to allude to the difficulty in treating PTSD. The fundamental aspect of the biology side is that PTSD is associated with the fight or flight response that mobilizes the sympathetic nervous system to ensure survival. And we talked a little bit about the locus coeruleus before, in that it's a norepinephrine, that it releases norepinephrine and fuels that fight or flight response. Another aspect might involve the hypothalamic pituitary adrenal axis that is activated by CRF, or corticotrophin releasing factor, and this also increases the activity of the locus coeruleus, increasing the norepinephrine release and fueling that fight or flight response by increasing norepinephrine and cortisol, which also increases, in turn, glucose levels. Acute stress response is attenuated by serotonergic transmission, and brain studies have shown that chronic stress does decrease hippocampal volume and increases the sensitivity of the amygdala. These changes might contribute to the inability to extinguish the fear response, but again, we still have trouble treating this disease. So for the clinical presentation, the patient is usually exposed to some type of traumatic event. The hallmark symptom of PTSD is unwelcome, persistent re-experiencing of a traumatic event through nightmares, flashbacks, or intrusive memories. People with PTSD, they're going to display some avoidant symptoms similar to some of the other anxiety disorders we talked about, and they might withdraw socially. Manifestations may be the initial reaction to the trauma, so the diagnostic criteria is going to be important, and the diagnostic criteria in the DSM-5 has actually changed, and it's actually changed a good deal, which makes it a little bit harder to talk about drug therapy. So most drugs for PTSD were studied based off the DSM-4 criteria, which they had 3 main categories of symptoms. With the new criteria, there's 4. So when I'm talking about drug treatment, I'm going to be talking about some of the older criteria, but you also need to know the newer criteria to understand how it's diagnosed. But no medications have been studied using the newer criteria at this point. So the diagnostic criteria is they need to be exposed to a traumatic event. And we'll go through each one of these symptom categories. They'll have at least one intrusion symptom, this used to be called re-experiencing. At least one sign or symptom of persistent avoidance, at least 2 negative alterations in cognition and mood, and at least 2 symptoms of increased arousal. And the arousal and avoidance used to also be a category. The symptoms from each category must be present for 1 month or longer. If it's less than a month, it's usually called acute stress disorder. So the traumatic event, the person had to experience, witness, or be confronted with an event that involved actual or threatened death or serious injury. The intrusion symptoms, which I mentioned before, used to be called re-experiencing symptoms, and these can be recurrent, intrusive, distressing memories of the trauma. In children, they might not have these memories. They may play in themes of the trauma that occurred. So like playing car accident or something of that nature. Recurrent disturbing dreams of the event. Children might have trouble recognizing the specific dreams and what they are. Feeling that the traumatic event is recurring, and again, reenactment may occur with these patients or children. And intense or prolonged distress after the event and physiologic reaction to reminders of the trauma also qualify as intrusion symptoms. They also need to have at least one avoidance symptom, which is avoidance of thoughts or feelings of the trauma, or external reminders such as people, places, conversations that remind them of the event. Cognition and mood is the category itself is new within the diagnostic criteria. But some of these used to be in other places within the PTSD diagnosis. So these types of patients will not be able to recall key features of the event. They'll have persistent negative beliefs about oneself or the world, and persistent negative trauma-related emotions like anger, guilt, shame, when it may not be relevant to what actually occurred. They may feel alienated and have a persistent inability to experience positive emotions. This is also called anhedonia. And they may have markedly diminished interest in some of the activities that they were doing prior to the trauma. The last category, the hyperarousal symptoms, this was also in the DSM-4. These types of patients will have decreased concentration. They'll be easily startled, so if they hear a loud noise, they may jump, they may be hypervigilant, they may have trouble sleeping, irritability or anger outbursts, and they may display self-destructive or restless behavior. Now, there are 2 different PTSD specifiers, one with dissociative symptoms if they have either of the below, either depersonalization, experience of being an outside observer or detached from oneself. So sort of like you're watching yourself or you feel like it's a dream. Or derealization, experience of unreality, distance or distortion, thinking the world around you is not real. And then we have delayed onset, and this is when the PTSD occurs at least 6 months after the trauma. And it must be differentiated from acute stress disorder. Acute stress disorder usually is experienced immediately after the trauma. It may last around 2 days and resolves within 4 weeks. And the symptoms have to emerge within 1 month of the traumatic event. So there are non-pharmacologic therapy that we can use to treat PTSD. And this may be useful alone in patients with mild symptoms who don't want to use pharmacologic therapy, or in combination with pharmacotherapy. Studies have not found a difference with using combined therapy, but those studies have had limitations, so sometimes this is still used. Psychotherapies include anxiety management, cognitive behavioral therapy, and psychoeducation. And cognitive behavioral therapy is the most effective in clinical studies. It can be used in the acute time after to try to prevent PTSD. Although it is possible that psychotherapy could cause re-traumatization of the event to the patient. There's also something called eye movement desensitization and reprocessing. Overall, the overall arcing theme of this is very similar to CBT, except for the eye movement part. So it makes sense why this works. But in one trial, it was found to be better than fluoxetine at 8 weeks. But more studies, of course, need to be done comparing it to other pharmacologic therapies. PTSD symptoms respond slowly to pharmacotherapy, and some patients may never experience a full resolution. And this might be due to the incomplete knowledge of the pathophysiology surrounding this disease. Antidepressants are the mainstay of therapy, and usually we're going to start out with an SSRI. But if that fails, then we're probably going to switch to another one, although we don't necessarily have the data to support that. Patients should be monitored every 2 weeks initially until they have at least a 40% reduction in the frequency and severity of the PTSD symptoms. So here's our treatment algorithm. Make sure to maximize the dose. We could be starting off with our SSRIs or venlafaxine. If there's no response, we could switch to another one of those agents. We could maybe possibly use mirtazapine or a tricyclic antidepressant. If we have partial response, we could consider augmentation. Treatment is going to be continued a little bit longer in this disease, and it's going to be around 1 to 2 years. And if there's no response, we might be pushing towards phenelzine or some of the different augmentation therapies on top of an antidepressant. So SSRIs have been shown to be effective in all 3 PTSD clusters. Those are the DSM-4 PTSD clusters, the re-experiencing, avoidance, and hyperarousal, as well as treating symptoms with PTSD such as impulsivity, depression, suicidal thought, and obsessive thinking. Sertraline and paroxetine are approved for the acute treatment, and sertraline is approved for the maintenance treatment. And the response rate's approximately 60% with sertraline. Fluoxetine has also been studied, and the response rate is similar to sertraline and paroxetine. There are some smaller studies that suggest effectiveness with citalopram, although fluvoxamine has shown to not be effective in 2 different studies. Other antidepressants that we could use are tricyclic antidepressants such as amitriptyline and imipramine and phenelzine, but all these are associated with more side effects. Phenelzine does decrease insomnia, nightmares, and flashbacks, and is an alternative to patients who fail SSRIs. Trazodone can be useful for patients that experience a lot of nightmares and insomnia. And mirtazapine has an effect on the global rating of symptoms. When we're talking about global ratings, it's talking about just the symptoms across the board. How well, and one way you could find out someone's global rating is like, how well are you feeling today? Bupropion has been shown to be effective for depression, but not the symptoms of post-traumatic stress disorder. And venlafaxine did decrease some of those avoidance and hyperarousal clusters. SSRIs, though, improve all the different clusters. So I would start with an SSRI first. Nifazanone may be effective for these patients, but it does have a high risk of hepatotoxicity. And then we have our augmentation, which is not monotherapy. So you shouldn't be using antipsychotic agents alone. It should be used in addition to something else in someone that's not responding well. Mood stabilizers, again, they can be used as augmentation. And they are especially effective for impulse control and reduction in violent and angry outbursts. Anti-adrenergic drugs such as prazosin and clonidine do have some role in reducing hyperarousal and intrusive symptoms. And then antipsychotic agents have a variety of evidence with them, but they are controversial and should only be used as augmentation therapy. One important note that there's no current evidence for using benzodiazepines. And it's postulated to be related due to decreased benzodiazepine binding in the prefrontal cortex. And it can actually potentiate some of the fear response in PTSD and worsen recovery. So you really want to avoid those in these patients. And there has been an open label study that suggests buspirone may be effective, but it's not something that we're going to go to right away. This is an evidence-based table that I pulled from the VA treatment guidelines from 2012. It talks about the different DSM-4 categories that we've been talking about for treatment, but remember DSM-5 categories are going to be used for diagnosis. And how that will play out as we move forward with future studies will remain to be seen. I think that many of the newer studies may or may not. Maybe they'll use both DSM-5 and DSM-4, but it's going to be hard because the terms are changing. They don't necessarily mean the same thing. We'll pick up with obsessive compulsive disorder next.